All right. So we are going to go through in this. Oops, 1 second. Put myself here. Screen. Okay, so we'll go through the heart now. So we talked about what blood pressure is. So now we'll talk about the heart. Okay. So this unit will be, or this part of this chapter will all be about the heart. Okay, so I will skip the parts of the heart that you should know. You should already know from anatomy, right? Size you should already know from anatomy. Okay. You should know where all the valves are. You should know what all these terms are. Okay. Okay. So all the blood flow stuff you should already know. The coronary. Okay. So first thing I'm gonna go over you guys is this. Okay. The cardiac muscle cells and how they actually function. Okay. First of all, cardiac muscle cells can contract without innervation. Okay. This is very, very different than skeletal muscle. Skeletal muscle, okay, do not need or do not contract without innervation. The cardiac muscles, smooth muscle do. Okay, they have autorhythmic cells or pacemakers. Okay, so these cells will automatically signal for contraction on their own. They leak, and when they leak, they leak, and they cause the contraction to happen. Okay. Okay. So cardiac muscle versus skeletal muscle, they're smaller, they have one nucleus, whatever, blah blah. They actually join neighboring cells through intercalated discs, and they have gap junctions. Okay. They have more mitochondria because you're constantly using your heart every single second. So you need more mitochondria to produce energy. Okay, so cardiac muscle. Okay. We're going to skip the EC coupling and stuff like that. Okay. But what I want you to focus on is the differences between skeletal muscle and cardiac muscle. Okay, and this is a big one. Okay, when you look at this is the cardiac muscle. Okay, this is the skeletal muscle. Okay, the cardiac muscle, the refractory period is almost as long as the entire muscle twitch, and therefore, okay, your cardiac muscles can never get into tightness because they have to relax, and like the whole twitch will be over by the time you're done relaxing. By the time the refractory period is over, your muscle can contract again, and so you never get tetanus. So this is tetanus, and you remember that from skeletal muscle. Okay. Okay. So one of the big differences is that you can the muscle contraction, okay, of cardiac muscle fiber is longer, but the relaxation is longer, and the refractory period is longer. So you can never have switches built on top of one another. Therefore, you can never have tetanus. Okay. Okay. So the pacemaker. How the pacemaker works is the pacemaker will naturally leak, and that will allow them to cross the threshold, and the threshold will allow calcium to come flooding in. Okay. And it will cause an action potential, and then the action potential can spread. Okay, so okay, so if you the most important thing between skeletal muscle and heart really is the duration of the action potential and the refractory period. Okay. 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 Um, so the heart as the internodal pathway begins from the SA node to the AV node. Okay. So that signals the heart fills from apex to base. Okay. Um, okay. So the Purkinje fibers transmit the electrical signals from the AV node to the left and right bundle branches. Okay. So the first thing is the SA node. Okay. The SA node sets the pace of the heart at about 70 beats per minute. That's what the average heart rate is. In reality, the SA node by itself actually sets the pace of the heartbeat at about 100 beats per minute. Your vagus nerve, in combination with the SA node, sets the pace of the heartbeat at about 30 beats per minute. Okay. If your AV node doesn't work, your if your SA node doesn't work, your AV node is also autorhythmic, and it beats at about 50 beats per minute. Okay. Your PG fibers even slower than that. They can act as heaters under conditions, especially the AV node. Okay, the SA node really doesn't have to work for your heart. It just helps a lot. Okay, your SA node contracts your atria, and your AV node controls your ventricles. Okay. Okay. All right. So make sure you understand this. Okay. The SA node causes the atria to contract, which then sends the signal to the AV node. The AV node then causes those bundle branches, bundle of His to the Purkinje fibers, which then causes the ventricles to contract. Okay. All right. Okay. So the electrocardiogram. Okay. One of the things you definitely should learn is understand what other parts of the electrocardiogram. Okay. Um, okay. So the electrocardiogram is not just the actual signals. It's actually the all the electrical activity summed up together. Okay. By not only the nodes but everywhere in the heart. And so you can see you'll see waves instead of just firing. Okay, so let's take a look. Okay. Okay, so first of all, when you look at an electrocardiogram, the electrocardiogram actually is occurs before the actual event. Okay, the actual contraction lags behind the electrical events. So the contraction follows the action potentials. So when we look at the action potentials, the mechanical stuff actually happens later. Okay, so at the beginning of the P wave. So this is a P wave. The P wave, okay, it signals the depolarization of the aorta. So this is P wave. Okay, so let me draw out. Yeah. So this is a P wave. This is a QRS interval. Okay, and then this is a T wave. The P wave is the depolarization of the atria. Okay, the QRS complex is both the repolarization of the atria and depolarization of the ventricles. Okay, and then the T wave is the repolarization of the ventricles. Okay, so okay, so make sure you know what all the parts are. Okay. Okay. So here's a ECG. Okay. Atrial contraction and the P wave. The PR segment. Okay, is where the signal goes through the AV node and AV bundle, and therefore you start the ventricular contraction and blah blah blah. Okay, so make sure you know what's happening. We'll play this video a little bit, so you should be able to understand that. Okay. Okay. So you should be able to read these. So the heart rate, I always think of the way I always think about heart rate is always the beginning of one P wave to the beginning of the second P wave. Okay, you use any repeating point, but usually I just use the easiest thing to see beginning of the P wave to the end of the P wave, or sorry, beginning of the P wave to the beginning of the next P wave. Okay. So beginning of P wave to beginning of P wave, one. So here, okay. So beginning of P wave to beginning of P wave. That is one heartbeat. Okay, and see this heartbeat is slightly less than 1 second. Okay, so it's about 70 beats per minute, right? So okay. Okay. All right. So make sure you can hear this.
The heart is one of our most vital organs and most active muscles in our body.
The heart is one of our most
vital organs. It will beat over 2 trillion times before you reach the age of 50. Health professionals use this simple device called an ECG, or an electrocardiogram, to measure the electrical activity of the heart. In this video, we're going to explain how an ECG works and what it will show you.
We're going to explain how an ECG works and what it will show you.
The heartbeat begins when the heart's pacemaker, the SA node, depolarizes.
The
electrical signal moves rapidly through the atria, then down the intraventricular septum to the apex, and up the walls of the ventricles. This signal causes the muscle cells along the way to contract. The ECG, invented by Dr. Wilhelm Einthoven, a Dutch physician, made this device to record and measure these electrical signals. One contraction relaxation cycle of the heart generates a series of waves on the ECG. A P wave, which represents atrial depolarization, followed by a QRS wave complex that combines ventricular depolarization and atrial repolarization. Finally, a T wave showing ventricular repolarization. An ECG is done by placing recording electrodes on the surface of the skin, where they can measure the electrical activity of the heart. 2 electrodes form a lead, 1 positive, 1 negative. The first ECGs were done with 3 electrodes. They were placed on the wrists and feet, and they formed a triangle around the heart. Recording from the 3 leads of the triangle gives us a picture of the heart's electrical activity from 3 different angles. Michael's going to help us show how this triangle works. These electrodes are going to help us conduct the electrical activity of the heart. The further we place these electrodes from the heart, the less
further we
voltage we'll be
place
able
these
to pick up from
electrodes
them.
to the heart, the less voltage we'll be able to pick
Because
up.
of this, we're going to end up placing the electrodes on the
Because
shoulders
of this,
and the hip.
we're going to end up
The
placing
shoulders
electrodes
represent
on the
lead
shoulders
1.
and the hip.
The left shoulder
The shoulders
representing the
represent
positive
lead
end,
1.
the right
The
shoulder
left shoulder
representing the negative
representing
end.
the positive end.
When the heart
the right shoulder
depolarizes,
representing the negative end.
current flows through
The
the
heart
heart
depolarizes.
and depolarizes,
Current flows
and both
through the heart
electrodes will pick
and
up the electrical
depolarizes.
signal.
And both electrodes will pick up the
If more activity is moving towards the positive electrode, we
If
see an
more
upward
activity is
deflection
moving
on our
towards the positive
ECG.
electrode, we see an
If the
upward
signal is stronger
deflection on
moving
our
towards the
ECG.
negative electrode,
If
we
the
have a
signal is
downward
stronger moving
deflection.
towards the negative
If the
electrode,
signal is
we have a
perpendicular
downward
to the
deflection.
axis of the lead,
The
both
signal is
electrodes get similar
perpendicular to the
voltages
axis
from
of
the
the
heart,
lead.
and the
Both
trace will not move off
similar
the baseline.
voltages from the heart. The trace will not
Now let's
move
look
off
at the
baseline.
actual output of the ECG.
Now let's look at the actual output
This
of the
ECG
ECG.
shows 6 heartbeats recorded
This
simultaneously from
ECG shows 6
Einthoven's 3
heartbeats
limb
recorded
leads.
simultaneously.
However, the traces are
Three
very
limb
similar, the different views
However, the
emphasize
traces
different
are very
waves.
similar.
For example,
Different
look at the QRS
waves.
complexes in leads 1 and 2.
For example, look at the
As the
QRS
electrical
complex in
activity
leads
moves
1
through
and
the
2.
ventricles,
As the
it's moving
electrical
towards
activity
the
moves
positive
through the
electrode of
ventricles,
lead 2,
it's moving
but it's
towards
almost
the positive
perpendicular
electrode
to
of
lead
lead
1.
2. It's almost
This
perpendicular
results
to
in a
lead
much
1.
smaller lead 1
This
recording
results
and
in
a
a
more
much smaller
pronounced
lead 1
lead 2
recording and
waveform.
more pronounced lead 2
To calculate the
waveform.
heart rate, we need to count as
To
many of the
calculate the heart
QRS
rate, we need to
complexes
count
as we
as many of
can
the QRS
and determine how
complexes as we
much time
can.
passed for those
Determine
beats.
how much time passed for
The
those
very
beats.
small boxes are 1
The
millimeter
very small
squares,
boxes are
and the
1
larger
millimeter
red boxes
squares.
are 10
And the
millimeter
larger red
squares.
boxes are 10
The trace
millimeter
always
squares.
runs at a speed of
The trace
25
always
millimeters
runs
per
at a speed
second.
of 25
So
millimeters
5
per
of the
second.
larger red boxes in
So
a
5
row
of the larger
represents
red
2
boxes in a
seconds.
row represents 2
In the
seconds.
century since Dr. Einthoven first
In the
used
century
the
since Dr.
ECG,
Einthoven first
scientists
used
have
the
realized
ECG,
that the more leads you
scientists
use,
have
the more
realized
ways you
the
can
more
look at the
leads you
heart.
use, the more ways
We
you can look
clinically
at the
now
heart.
use a 12-lead
We clinically now
ECG.
use a
The 9
12-lead
additional
ECG.
leads are 3
The 9
augmented limb
additional
leads
leads
and
are
6
3
chest
augmented
leads.
limb leads
The
and
3
6
augmented
chest
limb
leads.
leads use the same
The 3
electrodes that we
augmented
use for
limb leads use
Einthoven's
the same
triangle.
electrodes
The
that we
difference
use for
being that
Einthoven's
it
triangle.
measures the
The
electrical
difference
activity
being
of the
that they
heart
measures
with
the
all 3
electrical activity of
electrodes
the heart with
simultaneously
all
rather
3
than
electrodes
just 2.
simultaneously rather than
I've
just
placed
2.
the chest leads across the
I've
4th and
placed the
5th
chest leads
intercostal
across the 4th
spaces
and 5th
across the
intercostal
ribs.
spaces
They're labeled
across the
V1 through
ribs.
V6 as
They're
you go
labeled V1
across.
through V6
The
as you go
chest leads
across.
allow for a
The chest
cross-sectional
leads
view of
allow
what the
for a
electrical activity of the
cross-sectional
heart is
view of
doing.
the electrical
We can
activity of the
sometimes
heart is doing.
reveal things that
We
we
can
would not
sometimes
normally be able to
reveal
see
things that we would not
just
normally
using
be able to
Einthoven's
see
triangle.
just using Einthoven's.
Here's a printout from a 12-lead ECG.
Here's a printout from a 12
You
lead
can see the
ECG.
3 limb leads,
You can see
the
the
3
3 limb
augmented
leads,
limb leads,
the
and
3
the 6
augmented
chest
limb
leads.
leads, and the 6
The
chest
traces
leads.
for these leads look different because
The
they're
traces
measuring
for
the
these
heart's
leads look
electrical
different because
activity
they're
from
measuring the
different
heart's
angles.
electrical activity from different
Do you notice
angles.
anything unusual on this ECG?
Do you notice anything unusual on this
As we go
ECG?
across this trace for lead 2,
As we
you
go
can see
across this
everything
trace
looks
for
normal for
lead
the
2, you
first
can see
10
everything
cardiac
looks normal
cycles,
for the first
but
10
on the
cardiac
11th
cycles.
cardiac cycle,
But on the
something's
11th
different.
cardiac cycle, something's
Based on the
different.
typical shapes of ECG
Based on the
waveforms,
typical shapes of
which
ECG
wave does this
waveforms,
11th
which
cardiac
wave
cycle
does this
most
11th
resemble?
cardiac cycle most resemble?
It most resembles a QRS
It
complex
most resembles a
because of
QRS
its pointy and
complex
tall nature.
because of its pointy and tall nature.
Next, look at the timing of the waves.
Next, look at the
Would you call
timing of
this
the waves.
QRS
Would
early,
you call this
on
QRS
time,
early,
or late
on
compared to when
time,
other QRS
or late
complexes are
compared to
being
when other
formed?
QRS complexes are being formed?
This QRS complex occurs earlier than
This
would be
QRS complex
expected.
occurs earlier
This
than would be
abnormal wave
expected.
represents a
This
premature
abnormal wave
ventricular
represents a
contraction.
premature ventricular
These are actually
contraction.
commonly abnormal
These
heart
are actually
beats.
commonly
They're nothing to
abnormal
worry about when
heartbeats.
they occur in
They're nothing to worry
isolation
about when they
like
occur
this
in
one.
isolation like this.
Interpreting ECGs is not easy.
Interpreting ECGs is not easy.
Okay. All right. So make sure you kind of can follow this chart. Okay. Because this will definitely show up my test. Okay. And then the 5 phases of the cardiac cycle, okay, are also on the test. Okay, so let's talk about what all these terms actually mean. Okay, so beginning. Okay, so the beginning, the heart is at rest. Both the atria and the ventricles are resting. The atria are filling with blood from the vena cava. Okay, so the AV valves open, the ventricles start to fill. Okay, the atria contract. The last 20% blood volume is driven into the ventricles. So actually, when I learned it, it was much less than 20%. Okay, it was like 10%, 5%, but very little. So the last bit of blood is driven in ventricles, which means most of the blood follows by itself through gravity. Okay, and now we need to know what these terms are. The end diastolic volume. Okay. Okay, the end diastolic volume is the volume of blood that's in the ventricles at the end of ventricular relaxation. Okay, so the amount of blood that's in the ventricles. Okay. All right. Okay. So phases 3 and 4. Okay. So it's when the AV valves close, when the AV cuff, when the AV valves close, that's when you get the blood cell. Okay. Okay. So now there's no blood leaving. So isovolume ventricular contraction. Okay. The ventricle starts squeezing. Okay. And eventually, the semilunar valves open, and that is the when the blood is ejected. And so we talk about the end systolic volume. The end systolic volume is the amount of fluid that's left in the ventricle at the end of ventricular contraction. Obviously, there is going to be some fluid left over. So, okay, and that's going to be still in the ventricle. So the next number I have to make sure you guys understand is ejection fraction. Okay, ejection fraction is EDV over ESV. Oops, sorry, ESV over EDV. Okay, so the volume left over plus over divided by the volume that's in there. So, okay, actually, let me find a better definition of ejection fraction. I'll find that later. All right, we'll end this right now.